Good evening. Good evening, all. Indian Medical College welcomes you all to this online class. In today's session, we have Dr. Presenjit Raut, Professor and Head of Pharmacology from SIMS Bilaspur with us. He is having plenty of teaching experience and a passion towards teaching. He will be taking class on alpha blockers today. Good evening and welcome, sir. It's a great pleasure to have you here with us, sir.
Good evening. Good evening all.
Dear viewers, the live chat session is enabled along with this live stream. If you have any doubts, please type them in the chat section or join with us via Zoom application using the Zoom meeting ID 270 999 3428. Your queries will be clarified by him at the end of this session. Sir, you can share your screen to start the presentation now. Thank you, sir.
Okay. Yeah, is it visible?
Yes, sir. Yes, sir.
Yeah, good evening all. Good evening, students. As you know, I'm Dr. Presenjit Raut, MD, and I'm working as a professor and HOD in Department of Pharmacology. And today I'll be taking alpha blockers. Okay. So alpha blockers, as you know, these are the drugs. In this, we will see what are the functions of alpha receptors. Then we will see the classification, followed by the general effects, and followed by the individual drugs. Okay. So alpha receptor antagonist. What do you mean by antagonist? Antagonists are the drugs that are going to inhibit the action of the agonist. Okay, so agonist would be norepinephrine, it could be epinephrine, and other symptomatic drugs with alpha adrenergic receptors. So as you know, antagonists, they are going to block these alpha receptors. It means that it is going to produce an effect that is exactly opposite of these drugs. That is exactly opposite of the agonist. That is the norepinephrine, epinephrine, and sympathomimetic drugs. Okay, so these are alpha receptor antagonists. We can also call them as alpha blockers. Okay. Now, before going into details of alpha blockers, first we will need to see where are these receptors situated, what are the different types of alpha receptors, and what will happen if we are going to block these receptors. Okay, so in this diagram, you can see over here that this is the alpha 1 receptor, which is situated postsynaptically. You can see over here, this is the synapse over here, and this is the nerve or the neurogenic nerve ending over here, and this is the receptor tissue. This is the synaptic vesicle, this is the synaptic cleft, and after that is the postsynaptic part, and this is the presynaptic part. So you can see that the alpha 1 receptor, they are present on the postsynaptic side, that is on the other side. And the alpha 2 receptor, as we know that there are only two alpha receptor, one is alpha 1 and the second one is alpha 2. So alpha 1 receptor is present on the postsynaptic. You can see this is the postsynaptic one. Whereas the alpha 2 receptor, you can see that this is alpha 2 receptor, and it is located or situated, or the site of the alpha 2 receptor is presynaptic in location. Okay. And this diagram, you can see that these are the synaptic vesicle. This is the nerve ending or the neuronal ending. You can see this pinkish. So these are the synaptic vesicle. These are the sympathomimetic or the sympathetic nerve terminal, which contains the neurotransmitter. Now, as you know that the neurotransmitter in case of sympathetic nerve system is norepinephrine. So these synaptic vesicles, they contain what? They contain norepinephrine. And whenever there is a stimuli, that is when this nerve terminal gets stimulated by any stimulation, these synaptic vesicle, they fuse together, and the content of this synaptic vesicle gets into the synaptic cleft. Okay, so here in this diagram we can see that the content, that is the norepinephrine, which is the neurotransmitter in case of sympathetic nervous system, norepinephrine is getting spilled at the level of synaptic cleft. Now, when this norepinephrine comes over here, that is in the synaptic cleft, what happens actually is that it can either act on the alpha-1 receptor, it can either act on the alpha-2 receptor, which, as I've already told, is present presynaptically. Okay, alpha-1 receptors are situated postsynaptically, so it can act on alpha-1 receptor, it can act either on alpha-2 receptor, or the third thing which can also happen is that this norepinephrine can also be degraded by certain enzymes. We will not go into details of these enzymes, but you should know that this norepinephrine, which is present at the level of synaptic cleft, gets degraded by certain enzymes. And the fourth thing that can happen to this norepinephrine is that it can again go back into the synaptic vesicle. It can again go back into the synaptic vesicle. Now, in the case of sympathetic nervous system, this is very important, as by blocking this uptake, or it is precisely called as reuptake. Okay, so this is what you call as a reuptake phenomena. Now, this is very, very important, as we can block this reuptake phenomena, and by blocking this reuptake phenomena, what is going to happen is that we can increase the levels of norepinephrine at the level of synaptic cleft. Are you getting my point? Okay. So what is actually happening with the norepinephrine after it is getting spilled is that this norepinephrine can act on the receptors. This norepinephrine can get degraded. And the third thing that can happen is that it can be taken back into the synaptic vesicle from where it has been formed and synthesized. Okay. Now, one difference which you should remember in cases of alpha-1 and alpha-2 receptor is that, as I've told you, that the alpha-1 receptor are situated postsynaptically, and alpha-2 which are situated presynaptically. There is a little bit difference, as these alpha-1 receptors, which we also call them as these are heteroreceptors, okay? And the alpha-2 receptors, they are also known as autoreceptor. Now, there is a difference that when you're going to stimulate these alpha-1 receptor, it is going to cause activation. Okay, whenever you stimulate these alpha-1 receptor, it's going to cause activation or stimulation. But in case of alpha-2 receptor, it's entirely different. It's entirely opposite. That is, if you are going to stimulate the alpha-2 receptor, it's going to cause inhibition. Okay, mind it. Once again, I'm going to tell you that if you stimulate the alpha-2 receptor, as this alpha-2 receptor are autoreceptor, if you stimulate this alpha-2 receptor, they are going to inhibit the transmission. Okay, so that is the difference between mainly the autoreceptors and the heteroreceptors. And as you know that these alpha-2 receptors are autoreceptor, so if you stimulate this with norepinephrine, as this norepinephrine is the neurotransmitter in cases of sympathetic nerve terminals. So if you stimulate this alpha-2 receptor with the help of norepinephrine, it's going to cause inhibition. That is what is being shown over here. Okay. So now, as we are discussing alpha blockers, okay, as we are discussing alpha blockers, so what we are going to do is that we are going to block this receptor. That is what we are dealing with today. That is the alpha blockers or alpha receptor antagonists. So when we give an alpha receptor blocker or alpha receptor antagonist, it is going to block this receptor. Now, these receptor being the heteroreceptor, they will cause inhibition. Okay. But what is going to happen with the alpha-2 receptor, as I've told you earlier, these are autoreceptors, and when you inhibit these receptors with the help of alpha blocker or with the help of a alpha receptor antagonist, it's going to cause stimulation, just the opposite of what has been described over here. That is, as I've told you, that if you stimulate these receptors, it's going to cause inhibition, but if you inhibit these receptors, it's going to cause stimulation. So right now, what we are doing is we are causing inhibition because we are giving a antagonist, we are giving a blocker. So it's going to block this receptor, and that will lead to stimulation. We'll see afterwards whether this is required or not. What is to be remembered in this case is that if we are blocking the alpha-1 receptor, it's going to cause inhibition and only inhibition. Okay, so this is the basis of alpha-1 receptor inhibition and the alpha-2 receptor inhibition. I think it's very much clear. If you still have any doubt, you can clarify at the end. So functions of alpha receptor. So as you know that alpha-1 receptor, they are present at the level of vascular smooth muscles. So they cause vascular smooth muscle contraction, whenever there is vascular smooth muscle contraction, there will be vasoconstriction, and this can lead to increase in blood pressure. Okay, so this is what has been mentioned over here. The alpha 1 receptor, which are located at the level of vascular smooth muscle, that will cause contraction. There will be vasoconstriction. In cases of eyes, the alpha 1 receptors are present over there also, and they will cause pupillary dilatation, and that leads to mydriasis or pupillary dilatation. Now, this pupillary dilatation is somewhat peculiar in that this is what we call it as active mydriasis. This is what we call it as active mydriasis, because this is a drug which is going to stimulate the alpha 1 receptor, and that will lead to pupillary dilatation, and that is why we call it as an active mydriasis. The another type of mydriasis which we can see is of passive mydriasis, and that is caused by atropine. So you should be able to differentiate. Again, we will not go into details of what we mean by an active and a passive mydriasis, but limiting the time limit. So what you should remember is that by causing stimulation of alpha 1 receptor, the mydriasis which we get is a active mydriasis. Now, alpha 2 receptor, as I've told you, the basic difference between the alpha 1 and the alpha 2 receptor is that alpha 1 receptors are the heteroreceptor. They are located postsynaptically. Whenever we stimulate these alpha 1 receptor, it's going to cause stimulation, okay? And vice versa. That is, if we are going to inhibit this alpha 1, it's going to cause inhibition. But it's not so in case of alpha 2, as alpha 2 receptors are present presynaptically. And as I've told you, these are autoreceptors. And when you stimulate these receptors, it's going to cause inhibition, and vice versa. That is, if you cause inhibition, it will cause stimulation. Okay, so just opposite things will happen if you are going to stimulate this, and opposite things will happen if you're going to stimulate this. Okay, so by stimulating this, as I've told you, now we are discussing this only the agonist part. After this, we have to just opposite this. We have to just reverse this, and we will get the actions of alpha blockers. So alpha 2, as I've told you, if you stimulate the alpha 2 blockers as alpha 2 receptors, as alpha 2 receptors are located presynaptically, as they are autoreceptors, and if you stimulate this, they will cause inhibition of the neurotransmitter release. That is what we have seen in the earlier diagram. That is, if you stimulate alpha 2 receptor, it's going to cause inhibition of the neurotransmitter release, and the neurotransmitter in this case is, as we're discussing in the sympathetic nervous system, it is norepinephrine. Okay, so there is inhibition of neurotransmitter release. Also, in brain or in CNS, they cause the alpha 2 receptor are located at the level of brainstem, and if stimulated, these alpha 2 receptor, they cause decreased central sympathetic outflow. They are going to cause decreased central sympathetic outflow. Now, this is very important, as we'll see when we'll study the drugs which are going to treat, which are useful in the treatment of hypertension, that we are using certain alpha 2 agonist drugs, and these drugs, they are acting at the level of these alpha 2 receptors which are present at the level of brainstem. And when these alpha 2 receptors are stimulated at the level of brainstem, they are going to cause decreased central sympathetic outflow. And when this central sympathetic outflow is decreased, what ultimately we get is, the ultimate result is there is decrease in blood pressure. Okay, so again, we'll not go into detail. What you have to remember is that what is going to happen when you stimulate the alpha 1 and what is going to happen when you stimulate alpha 2. So the basic thing which are going to happen when you stimulate alpha 1 is that there will be a smooth muscle contraction, and when we say smooth muscle, the vascular picture should come into mind, and there is a vessels should constrict, there should be vasoconstriction, and that can lead to increase in blood pressure. In eyes, there will be pupillary dilatation, and that leads to a particular type of mydriasis that is known as active mydriasis. There is one more type, as I've told you, that which is called as passive mydriasis. So that is caused by different drug, and the mechanism and the other things are entirely different. Alpha 2 receptor, as I've told you, is inhibitory receptor. So if you it's going to act in opposite direction, in a reverse direction. So if you're going to stimulate this alpha 2, it's going to cause inhibition, and that is what is happening over here. If you stimulate the alpha 2, there will be inhibition of the transmitter release, and the alpha 2 receptor which are present at the level of brainstem, if you stimulate these alpha 2, there will be decreased central sympathetic outflow. Okay, so this is what is going to happen when you're going to stimulate these receptors. Okay, now what we are actually discussing is the alpha blockers, okay? The alpha blockers or the alpha receptor antagonist. So what is going to happen when you give these drugs, which we are going to discuss now, the classification of alpha receptors, alpha receptor blocker drugs, that whatever things which we have discussed till now, these are the actions of agonist on alpha 1 and alpha 2. Whatever is going to happen will be just opposite to whatever we have discussed till now. Let us see first the classification. So this is the classification of alpha receptors blocker, alpha blockers or alpha receptor antagonists. So we can classify them as non-selective and selective ones. The non-selective can again be classified as irreversible and reversible. Okay, so first we should look at what do you mean by non-selective and what do you mean by selective. Now, when we say non-selective, it means that, as you know, that alpha receptors can be classified into two types, that is alpha 1 and alpha 2. Okay, so when we say this alpha receptor blocker or alpha blocker is a non-selective type, it means that it's going to block both the alpha 1 as well as alpha 2. Okay, so these drugs, that is, you can read this is phenoxybenzamine and this is phentolamine. Okay, these two drugs are the drugs which are going to block both alpha 1 as well as alpha 2 receptors. Okay, got it? Now, when we say selective, which we'll see afterwards, what are the drugs under this category? When we say selective, it means that it's going to block either alpha 1 or alpha 2, not both at the same time. Okay, clear? When we say non-selective, it means that these drugs, that is these two, phenoxybenzamine and phentolamine, they are going to block both alpha 1 as well as alpha 2. And when we say selective, it means that it's going to block either alpha 1 or alpha 2 only, not both. Okay, otherwise it will be a non-selective. Got the point now? Fine. Now, what is the meaning of this irreversible and reversible? When we say irreversible, that is the only drug is phenoxybenzamine. When we say irreversible, that is phenoxybenzamine is an irreversible non-selective alpha blocker. What it means is that that is the blocking capacity of phenoxybenzamine. Blocking, when it blocks the alpha receptor, it blocks in such a way that after being blocked, it's not possible for the receptor to get detached from the blocker, Are you getting my point? Okay, so even if you bring an agonist, now agonist in this case would be, that is norepinephrine. As you know that norepinephrine is a neurotransmitter in sympathetic nervous system. So even if you increase the levels of norepinephrine, it's not going to reverse the blockade. Okay, it's not going to reverse the blockade. So that is why we call it as irreversible. And the reason why it is irreversible is that this drug phenoxybenzamine, it binds to the alpha receptor, both alpha 1 as well as alpha 2, with covalent bonds. And as you know, as you have studied in chemistry classes, that these covalent bonds are very, very strong bonds. So this phenoxybenzamine, when it binds with the covalent bond, and it's very difficult for the agonist to displace this phenoxybenzamine from its binding site. Okay, I hope this should be clear now. What is the meaning of irreversible? Just opposite to that irreversible, there is a word which we call as reversible. Now, by this time, you should be able to understand what you mean by reversible. That is when you bring an agonist, and agonist in this case would be noradrenaline. Okay, so when you increase the levels of noradrenaline, what is going to happen is that it is going to displace this drug, that is phentolamine, from its binding site, and that is why we call it as reversible. Okay, I hope this is clear. So how we have classified? We have classified into two types, basically non-selective and selective. Non-selective means it's going to block both alpha 1 as well as alpha 2. Selective means it's going to block either alpha 1 or alpha 2, not both at the same time. Under non-selective one, you have irreversible and reversible. Irreversible, you have phenoxybenzamine. Reversible, you have phentolamine. Okay, now we should proceed to the selective ones. Now, what you call selective, as I've told you, that it means that it's either going to block alpha 1 or it's going to block alpha 2, not both at the same time. So these are the drugs. There is a long list in cases of alpha 1. You can see the list is not ending. So there is prazosine, there is tazosine, there is doxazosine, there is tamsulosin, there is alfuzosine, there is urapidil, indoramine, and so on. Okay, so these are the drugs, but at least For UG's sake, the students of UGs should at least remember these first four drugs. This first four drugs, that is prazosin, terazosin, doxazosin, and tamsulosin. Okay. In alpha 2 category, that is selective alpha 2 blocker, you have one important drug, only one important. There are other also, but I have related it. There is only one important drug that should be remembered, and that is yohimbine. That is yohimbine. Okay. So this is the classification. Sometimes they ask in a question that classify alpha receptor blockers or alpha receptor antagonists. So this is how we can classify. Again, once again, we can see the classification is very important as far as UGs are concerned, as far as the DDS is concerned, and BS students are concerned. So classification could be a non-selective or could be a selective. Among the non-selective, there is irreversible, reversible. There is only one drug. Irreversible, there is phenoxybenzamine. The name is very, very lengthy. So try to learn it by heart. And the reversible one is phentolamine. It's quite confusing also. It both starts with P. So you should be careful while writing the names of irreversible as well as reversible. Irreversible is phenoxybenzamine. Okay. And whereas reversible one is phentolamine. Whereas in case of selective alpha-1 receptor blocker, there is prazosin, doxazosin, terazosin, tamsulosin, and so on. Okay, as I've told you that at least starting 3 to 4 drugs should be remembered in case of alpha-1. The alpha-2, you have only one drug, one important drug. There are other drugs also, but you should remember this name of this drug, that is yohimbine. Okay. Now, the general effect, as we know, what happens, we have seen that what will happen if you are going to stimulate the alpha-1 receptor, what is going to happen if you stimulate the alpha-2 receptor. Now, what we have to do when we give alpha blocker is just the opposite or just the reverse of what happens when you're going to stimulate the alpha receptor. That is, as you have seen in alpha-1 receptor activation, that causes vasoconstriction. So now what is going to happen will be vasodilatation. Okay, so whenever there is vasodilatation, there will be fall in blood pressure, and the patient should be told that when you take this drug, as it is going to cause vasodilatation, so there will be fall in BP, and you should be very much cautious that you might suffer from postural hypotension. Okay, so this is very, very important thing, a very, very important side effect that can be counteracted with the use of these alpha receptor blockers. Now, there is decrease in tone of smooth muscles in the bladder trigone, sphincter, and prostate. Now, this thing, you should also remember that alpha-1 receptors are also present at these levels, that is at the bladder trigone, sphincter, and prostate. Okay, and when you stimulate this alpha-1 receptor, which is located at this level, it is going to cause contraction. Okay, now what we are going to do, what we are giving is an alpha blocker. What we are discussing is alpha blocker, so it's going to cause just the opposite thing. That is, it's going to decrease the tone of smooth muscle in the bladder trigone, sphincter, and prostate, and therefore it's going to cause micturition. It's going to ease micturition. It's going to ease urinary retention. Okay, it's going to increase intestinal motility. That is not so important. Meiosis, as I've told you, that this alpha-1 receptor is present at the level of pupillary muscles also. Because of activation of these receptors, alpha-1 receptor at the level of pupillary muscles, there is dilatation. So thus the opposite of that would be meiosis, that is pupillary constriction. There is also contraction of vas deferens and related organs, as alpha-1 receptors are also present at this level, and that can lead to impotence. Okay, so you should be very much cautious when you prescribe these drugs to younger patients, to younger married adults, as they might suffer from this impotence because of the alpha-1 receptor, which is present at the level of vas deferens, and contraction of that can lead to impotence. Now we come to individual drug. The first drug is phenoxybenzamine. That can come as a short note to you people. Write a short note on phenoxybenzamine. So it's a haloalkylamine. That is the general chemistry of this particular drug. It has got great affinity to the alpha-1 receptor, but as I've told you that it's a non-selective alpha blocker. It means that it's going to block both the alpha-1 as well as alpha-2, but it has got more affinity to alpha-1 receptor. Okay. Also, it's a non-reversible alpha blocker. It's a non-reversible alpha blocker. It means that when it binds to this, you can see over here in this diagram, when we give phenoxybenzamine, this phenoxybenzamine, it blocks this alpha receptor with a covalent bond. As I've told you, this covalent bond are very, very strong, and hence it's very difficult to remove this or to displace this phenoxybenzamine to displace this phenoxybenzamine from its binding site. Even if you increase the levels of norepinephrine, it's not going to reverse this binding. Okay, so that is why we call it as an irreversible type of blocker. Actions, so as I've told you, it forms strong covalent bonds. So there will be reflex tachycardia, fall in BP. As I've told you that there is vasodilatation, so there is fall in BP. Now, why there is reflex tachycardia? That, as I've told you, that it blocks alpha 1 as well as alpha 2. Okay, now, because of the blockade of alpha 2, there is release of neurotransmitter, that is norepinephrine or noradrenaline, and this increased secretion of noradrenaline or norepinephrine can act on the beta receptor, because we are not going to block the beta receptor because these are only alpha receptors. So both alpha 1 and alpha 2 receptors are blocked. Okay. Now alpha 1, as you know, that they are present on the vascular smooth muscle. By blockade of these vascular smooth muscle, there will be fall in blood pressure. Okay. Because of the blockade of alpha 2 receptor, which, as I've told you earlier, are presynaptic, are autoreceptor, we are blocking this autoreceptor, so there will be more secretion of or more release of the neurotransmitter, that is norepinephrine. Okay, and when this increased norepinephrine comes into the blood or comes into the picture, it's going to act on the beta receptor, which are not blocked by alpha blockers, and hence there will be reflex tachycardia. So this is an important side effect of the alpha blockers, especially the non-selective ones, as they block both the alpha 1 as well as alpha 2. It also penetrates blood-brain barrier and may cause certain CNS side effects. Pharmacokinetics, it can be given intravenously, can be given orally, it accumulates in adipose tissue. Uses, important, it is used in case of pheochromocytoma and hypertension. Hypertension, as you know, is a condition of blood pressure, wherein blood vessel, wherein there is an increase in the blood pressure because of vasoconstriction. So if you give a drug which is alpha blocker, definitely it's going to act on the alpha 1 receptor which are present on the blood vessel, and it will cause vasodilatation, and there will be fall in blood pressure. Now, what is pheochromocytoma? Pheochromocytoma is a tumor of adrenal gland. Okay, it's a tumor of adrenal gland, and that secretes more of the neurotransmitter, that is norepinephrine as well as adrenaline. So when there is increase in this neurotransmitter, this will act on the blood vessels. Okay, and when this acts on the blood vessel, there is hypertension because of the vasoconstriction. So we can use it in pheochromocytoma because when we give this drug, that is the alpha blocker, they can act on the blood vessels and they can cause vasodilatation, thereby relieving the hypertension that is caused due to pheochromocytoma. I think you're getting my point. Okay, so ultimately what we are treating in pheochromocytoma is hypertension. Okay, what we are treating in pheochromocytoma is hypertension. And why there is hypertension in pheochromocytoma, I think it must be clear by this time that this pheochromocytoma is a adrenal gland tumor which secretes a lot of neurotransmitter, that is the norepinephrine and epinephrine, which acts on the blood vessel and causes increase in BP. So these are two important uses. Side effects is very much obvious from the effects that it's going to cause orthostatic, that is postural hypotension, which we have discussed so much earlier. Tachycardia, which is a reflex one. A reflex tachycardia, and how it happens just now I explained. Vertigo, again, which I have told you that it is going to enter into the brain and can cause some kind of vertigo. Okay, sexual dysfunction also I've told you, because it's going to act on the alpha 1 receptor which are present at the level of ejaculatory ducts. Okay, and because of this it can cause sexual dysfunction in males. Second drug is phentolamine. As I've told you, it's a non-selective, it equally blocks alpha 1 alpha 2, it's a short acting, uses are almost same. Okay, adverse effects are also almost same: hypotension, arrhythmias, nasal congestion, and headache. Arrhythmias can also happen with the use of phenoxybenzamine, as the beta receptors are not occupied or are not blocked by alpha receptor. Now we come on to alpha 1 selective blockers. The first drug and the foremost drug, this is the most important drug in this category, and this is the prototype drug. So whenever we talk about prototype drug, we call it as a prototype drug because this is the leader amongst this particular classification, and all the drug behave almost similar to this particular drug, and the drug is prazosin. If you see its chemistry, sometimes it also comes as a short note. Okay, so you have to be very much cautious. It is a quinazoline derivative. Its action again the same thing, but as you know that this is a alpha 1 blocker, so it's going to block only the alpha 1 receptors, not the alpha 2 one. Okay, because it's a selective blocker. It's a selective alpha 1 selective drug. So it's going to block only alpha 1 receptor, which is present at the level of vascular smooth muscle. So what we're going to get is vasodilatation. There is fall in blood pressure, and that will lead to postural hypotension. Okay, and that is what we call it as the first dose effect. That is fainting and dizziness. Now this is also very important, first dose effect, which is especially seen in cases of prazosin. It causes first dose effect. What is this first dose effect? Is that whenever we give a drug prazosin, the patient will feel fainting and dizziness, and that is because of vasodilatation. Fainting and dizziness because of vasodilatation. So you should be very much cautious. You should ask the patient to take precautions that whenever he will take this drug, he is going to get this fainting and dizziness. So you should instruct the patient that you should take this drug so as to avoid this fainting and dizziness. You should take this drug at the bedtime, because he is going to be recumbent at that time for at least 6 to 8 hours. Sorry. Second thing which you are going to tell to the patient is that whenever you start this drug, you have to start with a lesser dose. Okay, so we'll discuss afterwards that what is the dose and all those things. But you should remember one thing, that whenever you prescribe prazosin to any person or to any patient, you should be very much cautious that you should always give it at least possible dose. And as the patient gets adjusted to this particular dose, you should keep on increasing the dose. Okay, so this is what is known as the first dose effect, which is very much seen with this, the use of this drug, which is prazosin, which is a alpha 1 selective blocker. Pharmacokinetics, it's orally effective, it's highly plasmid proton bound, metabolized in liver, acid in bile. Uses again the same, almost same hypertension. We are not using it in pheochromocytoma, but we are using it in another condition that is known as benign prostatic hypertrophy or hyperplasia. Benign prostatic hypertrophy or hyperplasia. What is this? It's a, there is prostatic enlargement, as you all know that in elderly cases, especially in males, there is enlargement of prostate after the age of 60 years, and that enlarged prostate is going to constrict the prostatic urethra. Okay, so by giving this drug, as we discussed, that alpha 1 receptors are also present at the level of this trigone or the prostatic urethra. So when you give this alpha 1 blocker is going to block the receptor at this level, and it's going to relax the prostatic urethra, thereby easing the micturition. Now you can see over here what actually happens when you give prazosin or any other alpha blocker, alpha 1 especially. So without alpha 1 blocker, this is what is happening. This is the prostate, and it has narrowed this prostatic urethra. It has constricted the bladder neck as well, the trigone as well. So everything is constricted over here, and it's very difficult to pass the urine. Okay. Now, when you give this alpha 1 blocker, that is prazosin or any other alpha 1 blocker, this is going to relax this prostatic urethra or the trigone over here. And because of this relaxation of this bladder neck, the prostatic urethra, everything becomes very, very smooth. The person feels very, very comfortable, and there is no urinary retention. Okay. So we can use this drug prazosin and other, but we have got better drugs, so we do not use prazosin. As you already know that prazosin is a drug which can cause first dose effect. Okay, so it's a reserved drug. Basically, it's a reserved drug. We do not use it in cases of benign prostatic hyperplasia or hypertrophy, but we use it in only in cases of hypertension. Okay, we have got other better drugs. Let us see what are these drugs. The first drug is terazosin. Okay, terazosin. It is chemically and pharmacologically similar to prazosin. It's more water soluble, higher bioavailability, longer plasma T-half. That's a very important point. As compared to prazosin, it has got longer plasma T-half, so we can give it once a day. Duration of action extend beyond 18 hours. Okay, so we can give it once a day and use. It's more popular than prazosin in BPH. I told you earlier, prazosin cannot be given in case of BPH because it causes first dose effect. So better drug is there, that is terazosin, which can be used only and only in cases of benign prostatic hyperplasia or hypertrophy. Okay, the better thing is that it has got a longer plasma half-life, so you can give it in once daily dosing. Another drug is doxazosine. It's a congener of prazosin, similar pharmacological profile. Again, T half is much high, so we can give it once daily. That gives a much better patient compliance. Okay, and use it in cases of BPH and hypertension. The last drug is tamsulosin. Now, tamsulosin is a very selective. It's a, you can see over here, it's a uroselective drug. Okay, as we have labeled it, it's a new drug, and we have labeled it as a uroselective because you can see over here that it is going to block the specific receptor which is situated at the level of the trigone, that is the alpha 1A. As in earlier cases, that in case of prazosin, doxazosine, terazosin, and all these drugs, we have seen that they are going to block alpha 1. Okay, but now it is seen that the receptors which are present at the level of the urinary bladder are of alpha 1A type. Okay, so if you give a more specific drug, what is going to happen is that you will have lesser and lesser side effects, or the adverse drug reaction or the adverse drug events to that particular drug will be much lesser as compared to the other drugs which are very non-specific. So this, you can see that this drug tamsulosin, again, it's a very important drug. It's widely prescribed for the treatment of BPH. Okay, and can be asked as a short note, that a short note on tamsulosin. So you should be very much familiar with this drug, that is tamsulosin. Tamsulosin, which is a uroselective drug. I told you earlier, it's a alpha 1A blocker, and this is a receptor which is present at the level of urinary bladder, at the level of trigone, at the level of prostatic urethra. So it blocks this alpha 1A, causing relaxation of the prostatic urethra and thereby relieving the urinary retention. There is no serious side effect. That is also an additional advantage you get with the use of this drug tamsulosin. There is no serious side effect like postural hypotension, blood pressure, heart rate. There is no changes at the level of low doses because it does not block the alpha 2 receptor. Okay, so the uses is in cases of BPH, as it's a long acting drug, we can use it in single day, single 1 day dosing, that is of 0.4 milligram per day. The ADA could be dizziness, as there might be some entrance to the brain, to the CNS, and impaired ejaculation. As I've told you, that it can also act on the alpha 1 receptor which are present at the level of ejaculatory ducts, and that can cause impaired ejaculation. Okay, so I think this is all over for this today. Summary, let us just summarize whatever we have discussed. That the alpha blockers we have discussed today, so they are important in the management of pheochromocytoma. They are important management of BPH, that is benign prostatic hyperplasia or hypertrophy. They're also important management of hypertension as well as peripheral vascular disease. Adverse defects, that they can cause postural hypertension, reflex tachycardia, nasal stuffiness, and sexual dysfunction. I think, yeah, it's over. So now I hand it over to you. If you have got some doubts, you can just ask or let me know. Thank you, sir. Hello.
Thank you, sir. Thank you for
Okay.
the wonderful session. Thank you so much, sir.
Okay.
Dear viewers, if you have any doubts, please post it on your YouTube channel, or you can ask it via Zoom now. Sir, let's wait for a few more minutes.
Okay,
So
fine.
that if there is any
Okay,
queries,
no
we can
problem.
get it.
Fine.
Sir, I think there are no queries from the viewers.
Okay.
Viewers, you can still post your queries and get it answered on our Facebook page. And few more sessions are coming up for you next.
Can
You
I
have an
go
interesting
offline now?
session. You have an interesting session upcoming at 6:30 p.m. today. Thank you, sir. Thank you for the wonderful presentation,
Thank you.
sir.
Thank you. Can I go offline now?
Yes, sir. Yes, sir. Yes, please. Viewers, please do like our YouTube channel, that is tinyurl.com/Indian Medical College 2020. Just like our Facebook page, the fb.com/Indian Medical College 2020, or connect with us via Zoom meeting ID 270-999-3428. In 6:30 session, you have the presentation by Dr. Meenakshi, Diabetes mellitus Part 2. And this is the schedule for tomorrow's class. Thank you all and see you again.